I heard you, Susan. Yep.
Thank you.
Okay, I have 11 o'clock. I don't believe we have a quorum as yet. It looks like the TAC members that I have on is Anlin, Susan, and Evan. Are there any others that I may be missing? Okay, we need one more to have a quorum, so if you want to give it another minute or two, that's fine, or you can go ahead and start and maybe come back to the minutes later. It's however you want to do it.
Yeah, if you want to give us another minute, I'll try to round up a couple folks.
Okay, perfect. Thank you.
Thank you. All right, I haven't heard anything yet, so Anla and Susan, I don't know if we wanted to go ahead and just get started, and then we can come back to the action items, hopefully once someone else jumps on.
That's fine with me, Evan.
All right, Anla, I'll let you take it away. We can't hear you, Anlin. I don't know if you're on mute or. Yeah, it's not working now for some reason, Anlin. I don't know if you select a different microphone option with the little arrow to see if it's on the one you need. You want me to go ahead and jump in, Amlin? Does that work while you're working on that? Okay. All right, we'll go ahead and get started with old business, which is really kind of a group of recommendations we had made previously related to home health reimbursement rates, which I think are now at this point, 15 plus years haven't been changed. So we had recommended an increase to home health reimbursement rates. Likewise for supply reimbursement rates and a sort of policy consideration change to add supply only to DME services, as well as a publication of limits for MCOs and standardizing supply quantity limits. So those were all recommendations that were made previously. So just checking in with DMS to see if we have any feedback on any of those recommendations.
Evan, I do not have any feedback. Sorry, I think we're having some. Can you all hear me? I know I hear some like background, kind of some screeching or some noise in the back.
Yeah,
We're still looking at those. I will add the there was prior to oh, thank you, Susan, the Pleurex strain. So yes, the intention is to add that, the coverage for that. I need to do the change order. Some of the supply only. So there was a change order before home health moved to our division last year. There had been a change order done. That was only though for individuals under the age of 21. So it was for children. So in looking at just in general, the whole supply only, or just supplies in general, and what makes sense to be on a home health fee schedule versus what makes sense to be on DME, would also probably like to open that up to talk to you all about in the future. I don't know, maybe we might do a survey or do like a webinar to have some discussions about supplies just in general, and what makes the most sense for you, what you all think too, since you are the ones out there doing it. So and then we are still looking at the rates. So Evan, sorry, I don't really have an update other than we haven't forgot it. We are looking at it, and I will be doing a change request on the Pleurex strains. We've decided that we do want to cover that and add that to home health. So we will be doing the change request with the MMIS to get that done.
Great, that's good news on Pleurex. How can we, can we work directly with you, Pam, to follow up on any of that, or?
Yeah, you can, yeah,
Okay.
you can just follow up with me.
Perfect, all right, we'll stay on top of that. So no other updates otherwise, Pam?
Not
Or-
on that. I think we're going to talk about the big thing in the new business. So I'll wait till we get down there.
Okay, sounds good. All right, that's it for old business. Susan, anything else for the moment, or Anlin?
No, that's
Yeah,
all
well-
I had.
Oh, perfect. Do you want to take over, Anlin, or you want me to keep going?
Oh, you just keep going. You've done so well.
All right, new business, home health CON changes. We wanted to make the group aware of the proposed change for the certificate of need program in home health. That's been, I think at this point, sort of just recommended or proposed for the state health plan. And that change would allow hospitals, nursing homes, and one other group that I'm forgetting just at the moment, and I'll find that here in a second, but would allow them to have non-substantive review for any CON that they put forward for home health. The issue as we've been sort of explained on this particular topic is that for hospitals, they've run into some difficulties here and there for discharging patients in particular situations. This is something that, we're very keen to try and address, and we've submitted some comments to really try to push back on the notion a little bit that home health agencies are out there not accepting patients because, particularly our group is very interested in going above and beyond to try to admit as many folks that are appropriate for home health services as possible. So we have submitted some comments to the OIG on that topic, as well as a number of other groups to try to address that. But I think the biggest upshot here is if a change like this were to be made to give hospitals in particular, somewhat unfettered access to the home health arena, without having the traditional certificate of need process, that really puts some downward pressure on agencies with hospitals, the way that they can function and, operate and have programs and funding that home health doesn't have access to, that facilitates them, as well as having the size and scale that traditional home health doesn't have. This could potentially be some serious and ultimately really kind of devastating competition that would be put out there. So really have some great concerns with that proposal that's been put forward. We've been talking with the Office of Inspector General to make sure we've been transparent in all of those discussions about where we stand, and we've also offered an alternative, because as it stands right now, a hospital can already provide care for an individual patient in that same circumstance, so long as they provide the OIG with documentation and evidence that they have attempted to place that person in a home health agency. So really, it's already something that they can do. This change would make it a scale that really hasn't been seen before in terms of allowing hospitals and nursing homes to provide services really as they see fit, because while you still have to have a hearing under non-sub review, you're in a situation where none of the traditional requirements for CON exist. So with that, I don't know, Susan, Anlin, if you have any additional comments, but really that was just, we wanted to make the group aware of that proposed change, and comments were due right at the tail end of May. So I think the OIG is processing those comments and putting them under consideration, and may hopefully look to make some changes in the proposed language in the state health plan. So that's where things stand now, but we would just wanted to make the group aware of that and have any appropriate discussion that we might need to have. So Susan, Anlin, I'll let you all if you have any additional thoughts or comments.
Well, my comment is I am part of a hospital system, so I have a unique perspective on that from what I'm associated with. And it has opportunity for me, but it also has concern for me to think that other people could come into our space. The hospital systems have the same problems that we do. It's not about us not being able to take care of them. They can't find staff to staff a hospital either. So, I would just caution that it's not a true fix for the problem. And adding more people to the mix does not mean more patients with multiple payers, including Medicaid, will be taken care of. And that's my politically correct answer.
Anlin, anything else to add there, or just leave it at that?
Nope, I think Susan covered it.
All right, any other comments from the group? All right, we'll move on to the EVV update. So really, I'm curious, I know Pam, you've indicated us that we've got a contractor selected, so really wanted to just see where things stand as far as that goes, any additional launch details. And, you know, I think our group really just wants to reiterate our concern about readiness for moving forward. You know, I think folks are doing their best to kind of stay up to date, but you know, really want to make sure we're ready to go once that program's ready to launch. So I'll turn it over to you, Pam, for this further discussion on that.
So Therap is our is the selected vendor. They have been doing EVV for many years. They're in many other states. We actually have some providers that are using Therap. We had a kickoff, well, our second in-person meeting with them yesterday. And coming out of that, we are going to begin reaching out to, there'll be communications going out to providers about expected timelines, training. I think there probably will be potentially a survey that goes out to kind of capture preferred methods of training, some preferred, just some knowledge barriers. The system, from what we saw yesterday, the demo, very user friendly, very intuitive to use. I think that things are going to move quickly because obviously they have to. We have a 1/1/24 deadline that's looming out there. Therap is the name of the provider. It's THERAP. So look for, in the coming, in the coming couple of weeks, information coming out about how we're going to approach training, just general information about them. I'm really excited after we met with them yesterday and saw, additional demos of the product. I think that they are going to be a good fit for Kentucky. And like I said, they are in use in Kentucky by some providers already. I don't know if it's more on the personal care side, or I think we do have maybe a home health agency that is using them today, but they're going to be, they are up for the challenge. They've done this quickly in other states. So I think that we will, things will start happening soon. We're working with the different MCOs because, of course, this is a different component with this than PCS, is that we have, the MCO piece of that as well. As far as the MCOs go, there'll be, there's an option whether the MCO wants to use Therap as their, their EVV solution, or allow individuals to have third parties, but Therap will be the aggregator for everything, meaning all of the data will come from everybody. Ultimately will end up in Therap for us to do reporting. But so changes to start happening quickly, information to start coming out quickly, but very excited to welcome Therap on board and to get started.
Thanks, Pam.
I have a question. Would it be beneficial to have Therap come to maybe our next meeting or schedule a one-off meeting with them, so that as a provider, I'm not sure what I should be doing from a system standpoint?
I think there'll be a larger webinar, Susan, versus bringing it to the TAC where we're not reaching everyone. So I think there'll be a larger webinar where, any home health agency is encouraged, which I know they can attend, they can attend the TAC as well, but where we will cover specifically just EVV and where it will be, encouraged. And then we will also record it so that anybody that's not able to attend, but yeah, we're absolutely planning on doing that, sooner versus later so that there's more information.
Can you
out.
make sure that Evan gets those training dates so he can send it out to the membership?
I will, yes, I will do
Thank
that.
you.
And they're gonna be at the conference, Susan. So that'll be another touch point. They're gonna do a separate session and have some folks at our conference in August. So that'll be a good touch point for them.
And we also talked to them yesterday about, and we couldn't do this with PCS because, you know, it hit right during COVID, but also doing some in-person sessions. So doing some town hall type sessions across the state as well. So.
Great.
This is Anlin. Can you hear me?
Yep.
Okay. Did you say that the MCOs can select a different vendor?
They can, yes.
Okay. Yeah, I have lots of fears about this. Like, I've never even heard of that, and everything I've talked about with my software vendor is it all going to one place.
Well, and it
And of
does
course-
as the aggregator. So Therap is the aggregator, but we as Kentucky chose an open model, which means that we provide a vendor for free, which is, or agencies, and we have several agencies that already had been using EVV. They,
Am I the only one that
third
lost her?
parties have to send that to the aggregator, but they can continue to use their third party vendor. So if they have purchased a different software, for example, ClearCare is a big one, then they can continue to use that. That data just has to be sent to the aggregator, which in this case is Therap.
So can I have a question. So if you are a home health agency and you have in the MCOs pick different vendors, so we would have to potentially contract with 5 different vendors to be able to submit our information depending on what vendor the MCO chooses? And is there a financial aspect related to being with each vendor for the
Not if
provider?
you choose the vendor that is offered. So for example, if you chose to use Therap, then there is not a cost to you as an agency for that. The cost would come if you decided to purchase your own software. So if you decided to purchase your own software and have your own EVV vendor, that cost would be on your agency. But if you choose to use what is offered by the state, then no, there is no cost to the agency.
So and I'll just use WellCare, if WellCare chooses that other vendor you suggested, that's their choice. We still use Therap.
So,
I guess I just don't
and to be honest,
understand.
Susan, we kicked off yesterday, and so we have not had the MCO kickoff. So I really cannot, and I don't want, to be fair, I don't want to answer those questions yet, just because I don't want to give wrong information. So I think we need to still have that conversation with the MCOs. That is coming, that meeting is coming up. And then we will share, obviously, we know time is critical and we need to share that information with you all, but I don't want to share incorrect information.
Well, the reason I ask is immediately after I was notified that Therap was the chosen vendor, I reached out to my EMR and said, this is the vendor for Kentucky. When they already work with Therap, that should be good to go. But if the MCOs require us to do something different, then I would have concern. And I guess more to come because I just don't understand it.
Right. I think we just don't have the answer. I don't have answers to that, right? We do not, the intent is not to make it difficult and burdensome on the providers. I just have not had the opportunity, now that we've chosen Therap, everything's been signed, to be able to have that. We have not had that kickoff meeting with the MCOs yet. That is coming very soon. So I don't want to give incorrect information right now.
Just to clarify, Pam, though, so each of the MCOs can choose their own aggregator that would then have to communicate with Therap, or?
The aggregator is Therap for every.
But you're saying that each MCO could choose their own individual?
Some of
EVV
them
provider?
already, some of the MCOs already have EVV vendors. They already, in the initial survey that we did with them, some of the MCOs are already using EVV. So they already have a vendor and have been using that, that's been in place. They still will be required to send that data to us. Now, if they are going, I don't know what choices they're going to make. It may be possible that they change with Therap being our provided solution. I don't know. I can't answer those questions yet, Evan.
But just from a individual provider perspective, they get to still select their own EVV provider. And then if an MCO has a different one, they would just have to connect, and have those two communicate. That has to come.
It would have to come to Therap. Yes, that's part of as the aggregator.
Okay.
Yes.
And Susan, most of the time, the individual EVV providers or EMRs, they generally spread that cost across all of their customers, or take it on themselves to connect and be able to communicate with any of the other ones that they're not already hooked up with. So we can help navigate that one, though.
Thank you.
All right. Anything else on EVV? Thanks, Pam, for the update.
No, just more to come, and it'll come quickly.
Lots to do before 1/1. All right. Next topic is claim modifier requirements for each MCO. So this one came out of, I think, in particular started with Aetna, where there was not necessarily a requirement to do modifiers for therapy billing, but a preference for adding those modifiers. And so I think there's been some discussion about whether these are going to be required in the future or not. So throwing that out there, both for the plans and Aetna specifically, but just in general as a question, will modifiers be something that we see as a requirement in the future? And does anyone currently, think have a requirement on their end?
This is Stuart on with WellCare. We do not have anything other than what DMS uses, the standard coding guidelines and DMS guidelines. I checked with our staff, and we don't have any unique requirements for modifiers.
Yeah, and this is Herb with Humana. We also default to the standard that the state uses. I will say but we do follow also the NCCI edits on only when it's an accurate edit that's required and the state is silent on. Other than that, we default to the state's billing requirements.
Hi, this is Anna from Passport, and we follow the same as the other MCOs.
And this is Sean
Hi.
Collins from Anthem. We follow the same as the rest of the MCOs as well. Thank you.
Hi, this is Suzanne from United Healthcare. I believe we follow the same. I don't believe there are any specific modifiers, but I would need to confirm that with my team. So I'll have to get back to you to confirm.
Thanks, Suzanne. I'll put my email in the chat, so if you want to get back to us on that.
Yes, thank you.
And this is Crystal with Aetna Better Health. Can you all hear me?
Yes.
Yes.
Okay. Aetna does have the modifier policy that became effective, I believe it was 6/15 of 23, and that notice was sent out to all providers. However, I've been speaking with Ann Lynn actually about the requirement, and I do think that it plays into home health a little differently than it would with our standard PT, OT, ST therapy services, because you all do use revenue codes to bill those, and it's set up in our system, to look at those revenue codes, G codes, et cetera. So those modifier requirements is to identify like the PTA or whatever that may be that's billing, but it's more so for those 900 codes and so forth. But if anyone has any questions about those, you can always reach out to me and we can walk through those.
So, Crystal, in the end, this is Anlin. Do we need to put the modifiers on there or not? Because I think in our last email, it was to use different G codes for PTA as compared to PT and OT and OTA to differentiate those.
Yeah, because home health is, like I said, it's a little different with the billing, where that it's revenue code based and not specifically those 900 codes or so forth. I would suggest using the appropriate G code for the PTA versus the PT. But I do think, it bases the payment and everything is driven off that revenue code. And because that rate is like a standard fee, the modifiers is they distinguish which payment applies for other provider types. So a PT may receive a higher reimbursement than a PTA does.
Is that something that, Crystal, it's possible for us to kind of collaborate on, get something in writing that we can send out to the membership? I know you guys sent out a notice, so if we can start there, that'd be awesome.
Mm-hmm.
And then
we have the notice. It's posted on our website. We also sent that out to anyone that signed up for our network notices that goes out. So that was, I believe, on 5/15 is when that notice was sent out, because it didn't actually go into effect until 6/15. But I'll be more than happy to get that over to whoever needs it. I can put my email in the chat.
Perfect. Thank you. All right. Anything additionally on that, Anlin?
No, I don't think so. I think it's something that the MCOs should look at. Since I do a lot of the billing or train the billers, I get all the time from the MCOs, oh, we do it just exactly like Medicaid, and that is never true. And then they don't want to tell you how they want it done. They want to just say, well, you should do it like Medicaid. Well, when I bill like I do Medicaid, Medicaid doesn't use G codes. Medicaid is a 321 type of bill. Not another MCO accepts a 321 type of bill. So I just really wish that they would tell the truth on what their billing rules are. And the same with modifiers. We don't bill any modifier to Medicaid. And WellCare requires modifiers on their supplies, and then whenever you talk to them about it, it's like, well, this is what you do for Medicaid. And no, it's not what we do for Medicaid. And then they say, well, we can't tell you how to bill. That's your responsibility. Right. And I'm like, well, you're just making me guess. So I just really wish they would all come up with a real and true guideline of how they want things billed. Because what they do is come back on audit, and I spend countless hours changing, rebilling, fixing, for stuff that we should have been told how they wanted to build in the first place. Anyway, that's my rant for the day.
And Evan, that falls right in line with our supply issues. Not knowing the billing quantities, it's the same principle there.
So this is Herb with Humana. Maybe it would be good to take Aetna's modifier policy and just have all the MCOs take a look at it and be very specific to that particular modifier requirements and see if that's something that would impact the other MCOs.
Well, why don't we get MCOs to follow Medicaid's policies?
Oh,
Well, this is Samantha
You're
with
getting
Humana
ready
Healthy
to say
Horizons.
that you follow Medicaid.
Well, we do follow Medicaid policy. So as you've been talking, the lady from Hayeswood Home Health, I'm sorry, don't know your name.
Hanlon.
Hi. We can certainly go back and see if there's a challenge with, like you said, the type of bill, how we're set up, because we basically take the Medicaid billing instructions and provider level manuals, and we built our system based on that. But if you're experiencing a challenge, we would love to have some examples so that we can take a look and do an investigation to see what's different, what maybe isn't set up the way the billing guidelines require for home health. Happy to do that if you're willing to provide some examples.
Oh, sure. And I'm sorry, I didn't catch which MCO you were with.
Humana.
Yeah, Humana Healthy Horizons.
Yep. Do you want me to send them to my provider rep? The examples?
I would ask that I'm going to put the email address here. It's our compliance email that gets all the information for tax. So I'll put that in the chat, okay?
Okay. Yeah, it would be nice if everybody went by the true Medicaid billing guidelines, or I don't even care what the rules are. Just somebody tell me what they are and how they want it done, and then that's how I'll do it. Just so long as I don't have to guess and get a denial and guess again, or get an audit and then fix everything and try it all again.
So it's in the chat, the email address. So please, send that information to Humana KY Medicaid at humana.com, and we'll start researching those examples.
Okay.
Thank you.
I will get them sent.
And this is Kelly. I will send everything in the chat out to the TAC members, so you don't have to worry about taking extremely detailed notes.
Awesome, thank you.
Thank you.
I think our next topic is along those same lines, right, Susan? We're about the billing of supplies, revisiting that discussion, and what are the current policies for each MCO, and what do providers need to know to bill supplies?
This is Stuart with WellCare again, and I met with our claims configuration team with Home Health, and they said that we follow DMS's requirements. We don't have anything unique for supplies.
Thanks, Stuart.
But I think, did you say you were with WellCare?
Yes.
On
yes.
your side, you might not have any unique issues, but on our side, I'm pretty sure we do have issues with billing quantities and limits with WellCare. My revenue cycle manager is off on FMLA, so I can't give you a specific example right now, but that was WellCare is what started this entire conversation multiple years ago.
Billing requirements. I mean, limits to me is different than billing requirements. I know we do have some CMS proprietary edits that we don't publish, limits that we don't
That's what we're
publish.
after, is what you don't publish. Because
okay, I thought it was billing requirements, and we're the same for that. But yeah, and we actually checked with CMS. The medically unlikely edits MUEs, and it is proprietary. And we actually checked with CMS, and they're not allowed to be published. So we do not publish those. We do not publish those limits on our home health fee schedule.
How do we square that circle, Stuart? Yeah, in terms of the provider not playing a guessing game with, what the supplies limits are. Is that something you can communicate to each individual provider rather than, publishing, or how can that best be understood?
Well, I mean, The limits are published, like I said, except for the ones that are proprietary. And the reason why CMS does not publish them is because it's a fraud, waste, abuse concern that if they publish those, and it's a higher, I think if it's anything over 4, I believe it is, if they publish it, then the concern is that providers will just happen to bill that amount, whatever the limit is, instead of what, the plan of care, the unique plan of care that's member centric. But otherwise, I mean, we do publish what the limits are, but we can't, we checked with CMS and they said, no, you cannot publish these.
So Stuart, could you tell us a difference between, so give us an example of what is a non-published supply and what is a published, and explain why one is one way and one is another?
Well, according to CMS's website, and again, we publish ours, but I believe it's anything over 4, where the limit is anything over 4. CMS does not publish it.
And what do you mean by anything over 4?
The units. They're called medically unlikely edits, MUEs, and they've got a website, CMS website, addressing it.
And if
And
I'm
they-
not mistaken, 4x4s are one of those items.
That are CMS MUEs.
I think so. And Anlin, correct me if I'm wrong. And that just might be the example that I've always had in my head. I don't know, but it's just an unnecessary administrative burden. And I mean, you bill, rebill, trying to know, you deny the whole line. Why can't you just pay up to what the limit is instead of denying the entire line?
Well, that I don't know. If you could send me a couple examples, I'll have that vetted with the team and look into that.
Yeah, and if you have examples for, I think for Humana, we'd be interested in knowing that as well. If you've seen that on our side.
Same with Anthem. Feel free to drop me an email. This is Sean Collins. I'll put it in the chat again.
Yeah, I'll put mine in there too.
This is Kelly. If you all just want to send me those, I'll get them to the NCOs. I'll drop my email in the chat.
And we'll just have to make sure we don't get each other's, because of HIPAA, each other's information.
So, hi, Stuart, this is Dr. Terrio. So like if I was gonna do a wound or a dressing changes, so I had to do them twice a day, then I would, guesstimate how many, 4x4s I was gonna need and then order that amount versus saying, give me the max. Is that what you're?
Yeah, the concept is you develop a plan of care, you assess the member's needs, develop a plan of care based on that, and then request that authorization based on that.
That makes sense.
So you do know, Stuart, that WellCare does not require authorization. So we come up with a plan of care and the nurse guesstimates what the patient needs. There is no authorization. If you would call WellCare and try to get an authorization for supplies, you're going to be told that it does not require authorization. So then we provide the supplies, bill it at the end of the month, and then just don't get paid. That's truly how that works.
Okay. If you could send me some examples, I will definitely, huddle with the team to look at them and research.
And then also, just so you know, where your team said that you all didn't have any special billing requirements, you all do require modifiers on your supplies, on all urological supplies and all wound care supplies. That is not what we bill how we bill Medicaid, traditional Medicaid. So yeah, they have come up with their own little modifier structure, and it's different than how I bill modifiers to Humana also. Because I just learned by trial and error how WellCare likes it.
And just so you guys have an understanding on our side, from my seat, my business office and my clinicians are in 2 separate places. So the clinicians do create a plan of care and give supplies based on said plan of care. And then the business office bills based on what is distributed. And I mean, the clinicians have no idea really if it gets paid or not. So, I mean, your mindset's kind of off there in that when it comes to fraud and abuse, maybe for scrupulous agencies. So I would suggest, you punish them instead of the good guys. And I consider myself a good guy.
Yeah, I mean, CMS controls the MUEs, the medically unlikely edits, and what's not published.
But then
But
how does CMS and Medicaid publish the DME fee schedules? I look at them, they have limits on them. I mean, it's not like they don't publish theirs. Medicaid publishes one.
Yeah, and I mean, I don't know. I mean, this is literally from the CMS home health website regarding this, and it may, vary with DME. I mean, I know there's spillover, there's crossover with DME. But there are, certain ones where CMS, it's proprietary and they will not publish it, and it's on their website. And they should stay.
We also, as Medicaid, we have to follow those MUEs as well. And so they are different than the limits that are on the DME fee schedule. And so, I mean, as Stuart is speaking, I mean, we don't publish those either. We can't. CMS does not allow it. But we do also follow those same edits.
And Stuart, our frustration is not at you. Personally.
Thank you. I appreciate you saying that.
We'll start with that one. No, but we appreciate the dialogue, but this is, Susan, this has been 3 years, I think, that we're, trying to really chase this down. And
it's been 3 years with you, Evan. It was a long time before that as well.
It's been ever since I've been on the TAC.
Yeah. So that's why there's a little bit of frustration. I mean, it's a long pattern of, we don't know what the target is, and that's all we're trying to do is just hit the target. So any help you can provide us as we're trying to narrow this stuff down, we appreciate it, and we'll definitely follow up, both within the TAC and within, our separate discussions with the MCOs to try to get some progress made on this.
Yeah.
And maybe I need to manage my staff to the point where we don't distribute supplies like we do, but we really do what's needed for the patient. We don't worry about that, but we would like to get billed for everything that's possibly could be billed for and collected on.
I understand. And again, we definitely appreciate examples, because anytime I talk to them about an issue, they'll say, give me examples so we can research. So we always need those.
Right.
And Stuart, just so you know, in the 5 years we've been doing this, examples have been given before.
Okay.
I mean, you might be new to this one, but we've done this many times over. And I'm just more confused as we talk, because I'm looking at the Kentucky Medicaid home health fee schedule, and I'm looking at ostomy pouches, the 60 per calendar month. Some of them are 31 per calendar month. Diapers, it says they get 192 per month. Checks or underpads, they get 150 per month. So they tell things that go over 4.
Yeah, and I mean, the MUE edits, I presume it doesn't apply to that, so it's probably not a broad policy or whatever. But I just know on the website they talked about that, the MUEs. I'm sure there's some things that are not subject to the CMS MUE edits limits.
Yeah, I mean, they're unlikely, right? They're unlikely units for that item in question.
All right. Any other discussion on the supplies, Susan Anlin? We're good on that for the moment.
Yeah, we beat it to death for today.
Well, we'll revive it and bring it back for the next TAC and do some follow-up in the interim. All right, general discussion. So first topic will go updates from any MCO, from all of the MCOs related to common billing issues, common PA issues, or any other home health specific issues you have to share. Stuart, since you're in the hot seat, we'll come right back to you.
Keep it rolling. When I talk, the only thing that the staff told me is that regarding stuff that's more of, I guess, would be a DME supply that home health can bill. Sometimes providers don't include the manufacturer's invoice. That's the only thing that they said is an issue that they're aware of. I don't know. I mean,
that's for DME across the board to include the manufacturers.
Yeah, I mean, the context was home health, and I guess there are some, I don't know, maybe not, some home health that you can bill, or maybe not, but when I asked them, they said that was the only thing that they were aware of. So I mean, I know that's DME. Okay, it's just solely DME. Okay, all right, then they got nothing else then.
All right, thank you.
Hi, this is Anna from Passport. I don't have anything to share. Wanted to know if anybody has anything for me for Passport.
Thank you.
Thank you.
Hearing nothing, we'll go on to the next one.
Hi, this is Holly with Anthem, and we also have none to report at this time.
And this is Herb with Humana. Same, though I will say I am definitely interested in going back to that prior conversation. Anything that you're seeing issue-wise for claims for Humana, we definitely want to know about them and maybe do something working with you all to improve the quality of those edits in our front door, so you'll see immediately if something was done wrong on your claims.
Thanks, Herbert. We'll be happy to provide you some examples. We're going to get to huddle internally and get back with you all for sure.
Thank you.
Hi, it's Suzanne from United Healthcare. The only issue that we had, and this isn't like super recent, and you all kind of touched on this earlier, the only issues we've had have been with some of our more rural counties finding home health staff, hearing that, again, it's just been a challenge that home health agencies have with staffing right now. And I know we had, want to say a couple months ago, some difficulty with some of those harder to reach areas, but nothing like recent comes to mind within the last 30 days or so. And I know that, excuse me, sorry. I know that staffing is still an issue, just based on what I've heard in this discussion today. I don't know of any billing issues that we have or any trends or anything, but I can certainly take that back to my team and ensure. I haven't heard anything on the PA side either, but if you have anything for United, you guys, I put my email address in the chat, and you can please feel free to reach out to me and let me know examples. As everybody has said, if you have specific examples of anything that you want to send our way and we can look into, I'm happy to do that and bring it back to you.
Thanks, Suzanne. I think that just leaves Aetna.
Hi, this is Crystal with Aetna. We don't have any known billing issues. I've not really heard of any kind of trends from our PA department. But as always, if there's any issues that come up or anyone sees something that they have questions about, please reach out and we will take a look at those and see what we can do to assist.
Thanks, Crystal. All right, I think we're on to any updates from DMS. Anything additional to share?
I don't think we have anything additional to share that we haven't already talked about.
Thanks, Pam. Anything direct from Commissioner Lee?
No, I do not have any updates from the commissioner.
Okay, Recommendations, I don't think we have any recommendations for today's meeting.
No.
And on the MAC meeting side, Susan will be our representative at the next MAC meeting. And our next meeting is August 15th. And I think that's all we have for today.
Hi again, this is Kelly again. I just wanted to remind you that because we didn't have a quorum on this time, that you will need to approve the minutes at the next meeting in August.
Okay.
Good. Yeah, thanks for the reminder.
Sure.
All right, unless anyone has anything else for the good of the order, I think we can go ahead and adjourn.
Thank you.
Thank you all.
Everybody have a good Tuesday.
You too.
You too.
Have a great day.